Chapter 24, Personality Disorders. Personality disorders can be divided into three clusters. In Cluster A are your eccentric disorders, such as paranoid, schizoid, or schizotypal. Within Cluster B are the erratic, such as borderline, narcissistic, histrionic, or antisocial. And within Cluster C are your anxious disorders, such as avoidant, dependent, or OCDs. Keep in mind that Cluster B disorders have your most socially impacting ones, such as antisocial personality disorder or borderline personality disorder. Let's start with our Cluster A disorders, paranoid, schizoid, and schizotypal. For a paranoid personality disorder, this has a prevalence of 2 to 4%, with characteristics such as long-standing distrust and suspicion of others, may be apparent in childhood, and have a lot of social anxiety within childhood. The goal for our nursing care is going to be to counteract the mistrust, adhere to schedules, avoid being overly friendly, use simple, direct language, and project a neutral but kind affect. For our treatment, we're going to focus on psychotherapy as opposed to group therapy. Group therapy is threatening to people with paranoid personality disorders. However, the group setting may be useful in improving their social skills. Role-playing and group feedback can work to help reduce their suspiciousness. We also may be considering anti-anxiety drugs and antipsychotics for more severe delusions. For a schizoid personality disorder, this has a prevalence of nearly 5% of the population, and the characteristics include symptoms that appear in childhood and adolescence, loners with poor academic performance, an increased prevalence of disordered family life. They avoid close relationships and suffer from depersonalization and detachment. Our guidelines for caring for a schizoid personality disorder: first, avoid being too nice or friendly. Do not try to increase socialization, and assess for symptoms the patient is reluctant to discuss. Also work to protect against the group's ridicule. For treatment, we're going to focus on psychotherapy, group therapy, antidepressants, and for this crowd, second-generation antipsychotics. While group therapy is not a good first treatment choice, it may be helpful after individual work. Even though the patient may frequently be silent, group therapy provides valuable experience in practicing interactions and getting feedback from others. Next would be schizotypal personality disorder. This has a prevalence that varies from 0.6 to 4.6% of the population, with characteristics including severe social and interpersonal deficits, anxiety in social situations, rambling conversation, paranoia, suspiciousness, anxiety, and distrust, brief intermittent episodes of hallucination or delusion, and can be made aware of their own odd beliefs. They also may be vulnerable to involvement with cults or other unusual religious or occult groups. For our nursing care guidelines, we want to respect the patient's needs for social isolation, be aware of and intervene appropriately with the patient's suspiciousness, perform careful diagnostic assessment for symptoms that may need intervention, such as suicidal thoughts and ideations, and also withhold any judgment or ridicule. We want to be supportive while the patient receives psychological treatment, while also investigating any possible involvement with cults, and consider low-dose antipsychotics. Next would be Cluster B, or erratic, these including histrionic or narcissistic, and we'll also wrap up the chapter by talking about the two most socially impacting Cluster B disorders: antisocial personality disorder and borderline personality disorder. Just as a good reminder, borderline personality disorder, antisocial personality disorder, those are going to be very difficult patients for you to treat, and we're going to give them their own special section here later on. In our first case study, Jim and Mercedes begin marriage counseling together in hopes, Mercedes says, of saving their marriage. The therapist quickly notices that Jim seems to think a lot of himself while putting Meredith down. When she expresses hurt, he either laughs or manipulates her into feeling guilty or backing down. The therapist also notices that Jim frequently boasts about how successful he is, as if he needs the therapist to know and admire him. For histrionic personality disorder, this has a prevalence of nearly 2% of the population, with characteristics including excitable, dramatic, and often high functioning. They have bold external behaviors, a limited ability to develop meaningful relationships, have attention-seeking, self-centered, low frustration levels, excessive emotions that may be provocative, smothering, and have no insights into disorder or their own role in ruining relationships. For our treatment is going to be psychotherapy. We'll also keep guidelines in mind, like knowing that seductive behavior is a response to distress. Keep interactions professional and ignore any flirtations. Model concrete language. Help the patient clarify inner feelings. Teach and role model assertiveness, and assess for any suicidal ideations. As Jim and Meredith's marriage therapist continues to work with them, she quickly discerns that Jim is not interested in changing his attitude or behaviors towards his wife. Although Meredith, like Jim, is financially successful, Jim manages all of their finances, and Meredith feels he exploits her income for his own advantage. Jim is hypersensitive to criticism and feels that, as the smarter male partner, he is entitled to a greater share of control over their finances. Next would be narcissistic personality disorder. This has a prevalence of 0 to 6% and includes characteristics like feelings of entitlement, exaggerated self-importance, a lack of empathy with a tendency to exploit others, weak self-esteem and hypersensitivity to criticism, a constant need for admiration, and less functional impairment or other personality disorders. Jim is diagnosed with narcissistic personality disorder. Given what you know about the characteristics of this disorder, what intervention strategies would you predict to be most helpful in working with Jim? When dealing with a patient with narcissistic personality disorder, we want to remain neutral, promote a stronger patient self-identity, avoid any power struggles or becoming defensive, and role model empathy. We also want to focus our treatment on patients not likely to seek help or confront shortcomings. Using a combination of cognitive behavioral therapy to deconstruct that faulty thinking, in combination with group therapy and lithium for mood swings. Next up would be cluster C, or anxious disorders, such as avoidant, dependent, or obsessive compulsive. In avoidant personality disorder, this has a prevalence of 2.4%, with characteristics like low self-esteem, shyness that increases with age, feelings of inferiority, reluctance to engage with new people, subject to depression, anxiety, and anger, and also preoccupied with rejection, humiliation, and failure. Guidelines for nursing care include friendly, accepting, reassuring approach. Don't push them, being accepting of their fears. Group therapy, exercises to enhance new social skills. Design exercises to prevent failures, and assertiveness training. For an avoidant personality disorder, there's going to be a lot of different treatment modalities, ranging from individual therapy, trust building, and assertiveness training, to group therapy, anti-anxiety drugs, and antidepressants. For a dependent personality disorder, this has a prevalence of 0.5%, with characteristics such as a high need to be taken care of, submissiveness, fears of separation and abandonment, manipulating others to take responsibilities, and intense anxiety when left alone. The guidelines for our nursing care include helping to address current stressors, set limits that don't make the patient feel punished, be aware of strong countertransference, use therapeutic relationships as a testing ground for assertiveness training, and that psychotherapy treatment is our priority choice. Next, we'll come back to obsessive compulsive disorder. This has a prevalence of 2 to 8% and characterized by rigid, inflexible standards of others and self, a constant rehearsal of social responses, excessive goal seeking that is self-defeating or relationship defeating, strict standards that interfere with project completion, and an unhealthy focus on perfectionism. When treating a patient with obsessive compulsive personality disorder, we want to guard against any power struggles. Remember that the patient has difficulty dealing with unexpected changes, and provide structure but with time to complete habitual behaviors. We also want to focus on both group and behavioral therapy, along with drugs like clomipramine or fluoxetine, Prozac for their obsessions, anxiety, and depression. A patient is admitted to your unit with a personality disorder. What are some important areas to assess? Priority 1 is going to be assessing for suicidal or homicidal thoughts. If these are present, the patient needs immediate attention. We also want to determine whether the patient has a medical disorder or another psychiatric disorder that may be responsible for these symptoms, especially a substance use disorder that could be contributing to it as well. We want to view the assessment about personality functioning from within the person's own socioeconomic background and ascertain whether the patient experienced a recent important loss. Personality disorders are often exacerbated after the loss of significant supporting people or in a disruptive social situation. We also want to evaluate for a change in personality in middle adulthood or later, which signals the need for a thorough medical workup or assessment for unrecognized substance use disorder. Next, we'll discuss the two most challenging personality disorders. Those are borderline personality disorder and antisocial personality disorder. Both are considered cluster B disorders. In our next case study, Sydney, 27, is dropped near an emergency department. Literally dropped. Two of her roommates force her bodily from their car and drop two large plastic garbage bags on the grass. Sydney, who is very unkept, stands shrieking, and an EMT standing near the outside entrance takes a few running steps to stop the car as it backs out. "What's happening here?" he says. "Sorry," says one of the women, "but we just can't take it anymore. She's uncontrollable and we're both afraid of her. She needs help." Or borderline personality disorder. Again, this is a cluster B disorder that's characterized by severe impairments in functioning, emotional lability, impulsiveness, self-destructive behaviors, antagonism, and splitting. That is, an inability to view both positive and negative aspects of others as part of a whole. The major features of this disorder are patterns of marked instability in emotional control or regulation. Now, they're very impulsive. They have very identity and distortions within their self-image, an unstable mood, and very unstable personal relationships. For borderline personality disorder, it has a prevalence in the United States of 1.6%. You have most likely met some patients with borderline personality disorder and are remembering them very well. For a comorbidity, 10% of them is suicide mortality rate, while 70% of them will attempt suicide. Borderline personality patients often have other coexisting mental illnesses and also substance use disorders at a rate of over 50%. Some risk factors are genetics, neurobiological, and cognitive. Sydney, the young woman who was dropped near an emergency department by her roommates, is brought into the ED, sobbing and shrieking the entire time. She has evidence of cutting up and down her arms, and she shouts curses at each female nurse and refuses to cooperate, saying that she is tired of everyone trying to tell her what to do. She calms down a little when a male nurse approaches. When asked why that helps, she says, "Women are jerks. Never trust other women. They're all mean." For our first audience response question, Sydney is admitted to the psych unit for evaluation. Which behaviors would be consistent with a diagnosis of borderline personality disorder? That be A, splitting, B, inflexible standards, C, lack of empathy, D, absence of remorse, or both A and B? And the answer here is going to be A, that's splitting. Borderline personality disorder is characterized by this, that is, seeing people in terms of bad or good with few in-betweens. An example from Sydney is her statement that all women are jerks in response to the calming effect of a male nurse, and is no doubt an impulsive response to her recent traumatic break from her female roommates. Inflexible standards is consistent with OCD, but not necessarily borderline personality disorder. Similarly, that lack of empathy and absence of remorse, not demonstrated in our patient at this time, are both associated with antisocial personality disorder, not borderline personality. When applying the nursing process to treating patients with borderline personality disorders, we want to use a semi-structured interview, along with specialized tools like the Minnesota Multiphasic Personality Inventory and other self-assessment techniques. We also want to make sure we're using appropriate nursing diagnoses, such as risk for self-mutilation, risk for suicide, risk for violence, social isolation, and impaired socialization. Finding the best approach that works with patients in the setting in which they're treated is important. Therapies such as dialectical behavior therapy and mindfulness-based therapies Offer staff evidence-based interventions, clinical structure, and formalized support for identifying best practices. And we also want to make sure we're emphasizing the importance of the therapeutic relationship and avoiding their manipulative behaviors. We want to provide clear and consistent boundaries, use clear, straightforward communication, calmly review therapeutic goals, and incorporate teamwork, safety, and responding as a team, making sure all of the healthcare providers are on the same page, because these patients can be extremely manipulative. We're going to have a wide variety of treatment modalities tailored to each unique patient situation. We'll have biological treatments with psychotropics geared to their specific combination of symptoms. And that'll be in combination again with those psychological therapies, especially cognitive behavioral therapy. For our next audience response question, which behavior indicates that Sydney, our patient diagnosed with borderline personality disorder, is improving? A, she cries when her roommate refuses to go to the dining room with her. B, she yells at the group facilitator when he points out that she's monopolizing the group. C, she informs a staff member that she is having thoughts of harming herself. Or D, she tells the evening staff that the day staff excused her from group to smoke when she got upset. And that answer here is going to be C. She informs a staff member that she's having thoughts of harming herself. She is proactively trying to help herself, while the other are very common forms of manipulative behaviors. Next, we have antisocial personality disorder. This is another cluster B disorder with a prevalence of 1.1%. And it has characteristics such as antagonistic behaviors, disinhibited behaviors, profound lack of empathy, absence of remorse or guilt. Symptoms peak in their mid-teens to 20s, though the symptoms may abate and improve on their own by age 40. The main pathological traits that characterize anti-personality disorder are antagonistic behaviors, such as being deceitful and manipulative for personal gain or hostile if needs are blocked. The disorder is also characterized by disinhibited behaviors, such as high risk-taking, disregard for responsibility, and impulsiveness. Criminal misconduct and substance abuse are also very common with this population. For our assessment, patients with antisocial personality disorder become defensive and do not tend to answer honestly. For our nursing diagnoses, our priority here is going to be risk for violence, along with impaired impulse control and impaired social interactions. Our goals and outcomes here are going to be abusive behavior self-restraint of their aggression, coping, social interaction, social isolation knowledge, health promotion and health promoting behavior. And keep in mind, these are going to be difficult to accomplish. These are very difficult patients to treat, and maintaining safety is always the top priority. When planning and implementation, boundaries, consistency, support, and setting limits. Identifying realistic choices. Using therapeutic communication versus manipulation. Our priority again is teamwork and safety, along with pharmacological interventions such as mood stabilizers. Remember, evaluation is going to be difficult and maybe unknowable. We want to help to motivate these patients by trying to learn to change their behaviors. We also want to make sure we're addressing those manipulative behaviors, especially bullying, openly along with the consequences. Anticipate and seek out team support for any aggressive behaviors, and try to reduce their anxiety and anger through physical outlets. For our treatment modalities, there are no specific medications, though these patients will very often have many comorbidities that will have proper medications identified. Mood stabilizers may help with the aggression. You could also possibly consider SSRIs, benzodiazepines, or Ritalin in the case of where severe ADHD is a contributing factor. For our psychological therapies, be aware that there is some evidence that this patient population may bond with their psychotherapists. We also consider a specific form of cognitive behavioral therapy, mentalization behavioral therapy, or MBT. It's a long-term treatment that supports the individual's ability to recognize and understand their own and other people's mental states, as well as to help them examine thoughts about themselves and others. Another option may be that dialectical behavioral therapy, which is similar to cognitive behavioral therapy, though it focuses on regulating emotions and being mindful. It's also useful in treating antisocial personality disorder. Wrapping up with some more audience response questions. Perfectionism is a trait likely to be evident in a person with which personality disorder? That be A, obsessive compulsive, B, narcissistic, C, antisocial, or D, avoidant? And that answer here is going to be A, obsessive compulsive. Persons with obsessive compulsive personality disorder try to control the environment through perfectionism and orderliness. Next, for antisocial, obsessive compulsive, and schizotypal personality disorders. These occur most frequently in A, adolescents, B, children, C, women, or D, men. And that answer here is going to be D, men. The prevalence rates for antisocial, obsessive compulsive, and schizotypal personality disorders are highest in men. As you advance and work more in mental health, you may be seeing a lot of these personality disorders already at your clinical site. Now, these could be very difficult patients to treat. You may know some of these patients with these traits outside of the medical field. They can be very difficult to deal with. You want to make sure you're always having a neutral demeanor, trying to build up that therapeutic relationship while holding firm boundaries. Anyway, that's all we've got for this chapter. I'll see you in the next slides.